Working now in cricket, the first thing people said to me was there is no ACLs in cricket, so it's funny that I'm doing this talk based on ACL rehab. Whilst it's not a high mechanism in cricket, and I think you will inherit previous ACLs from previous sports, or certainly there's 2 players in our team that just went to England for the Ashes that have a past history of an ACL. So whilst it's not highly prevalent from a mechanism point of view from cricket, I think it's certainly really commonplace amongst sport, and it's on the rise, certainly in the female stakes. So whenever there's an injury of any description, the first thing that the player will ask you is, when can I come back? Certainly the first question the coach will ask, when can I come back? Will I come back? When am I going to be ready? How will I know? Am I going to do it again? And largely, I think the thing that I want to just raise today is who's responsible for that decision. And it goes without saying that it's a collective decision, but even though we know that from clinical experience and from the literature, it certainly still doesn't always happen on a day-to-day basis. So hopefully my clicker was working. Yeah. So how do we make these decisions? Is it a bit of a guess? Is there a logarithm? And like we know with all science, there is no definitive answer at this point in time, but there is some good research to kind of point us in a bit of the direction. So for the player, success means going back and staying back. Sometimes I think, and certainly if you read Twitter, success is rated on how quickly you get someone back. They don't actually care if they're back 2 years later or they're back 5 years later, or if their knees got significant amounts of osteoarthritis. So I think success is determined differently by different people. But for me, certainly in the ACL space, it's about getting them back and keeping them back safely. So having worked largely for country as opposed to club, players can only play for one country. Unless you're probably, maybe Jofra Archer's played for 2. There's a few that have played for 2, but largely you can only play for one country. There is different bias around decisions potentially when it's clubland, because there's contractual obligations, and that player is effectively, influenced to some degree by what's happening at a contractual level. So as sports science and sports medicine professionals, we're largely judged on our injury rates and whether we get back our players back and we keep them back. So really I just want to touch on shared decision making, which is collectively getting all stakeholders involved. And when you work for a national sporting organisation, our stakeholders also include the states. If they're underage, it's their parents, it's the athlete. These days there's managers and agents and so forth that potentially on that periphery as well. So really it's about making sure that we're aware of what the key evidence is in each of our areas and how we can support the athlete to be at the centre of that decision and make the best choice. I don't know if there's anyone here from Richmond, but the Richmond media put out a really nice video of Alex Rance the other day in terms of the decision around him not coming back, and largely from the outside having no concept of what goes on that inside. It was very much a really good example, what seems to be a really good example of how this shared decision making is done at the elite level. Community level is a lot harder because all those stakeholders are multiple layers again. There's schools, they play for multiple sports. So in clinic land, where I have also worked largely for 20 years up until this year, it's even more challenging because there is a lot more stakeholders that you may not necessarily have direct access to. So what do we know? And this really is about collecting that best available evidence. So just a couple of things that I thought would be useful to kind of share in terms of what we do know is that ACL reconstructions are on the rise, and certainly with the growing rate of female sport and female participation in multi-directional sports, such as AFLW, they're on the rise. So this is just a snapshot in terms of some stats. So rupture rates in all sport is about 3%, high-risk sports of which cricket is not one, but rugby league, union, AFL and skiing is 3 times that. And in Australia, I don't know if you can see these lines, but the rise of ACL reconstructions is increased significantly, and this is a study that was published last year over a 15-year period. And the dotted line at the top, if you can't see, if anyone's red, green, colourblind, this dotted one here is the latest stats in 2014, 2015, and you can see that they're on the rise. Now that's for multiple reasons. increased opportunity for imaging. Largely before, we didn't think that 10-year-olds, 12-year-olds could rupture their cruciate. They certainly can, and they're captured more often. And so this is not the number of how many will go on and rupture, but how many will go on and have reconstruction. So the numbers are on the rise is the snapshot of that page. I think the other really big thing is that if they have one ACL, it's not just a year out of their sport from a technical constraint point of view, and certainly from participation, it is going to have lifelong repercussions. And the decision around when they go back and how they go back and in what shape they go back in is significant to what comes next, because we know that knee osteoarthritis is significant, and nearly, there's some papers will suggest that up to 100% of people that have an ACL injury 15 years down the track will have tibiofemoral OA, and there's certainly a lot more evidence now about patellofemoral OA, which is very debilitating, not only for the athletic population but for your quality of life in later years. So there is significant burden in that time period of the acute injury and that acute phase of rehab, and certainly there's long-term consequence. So it's on the rise. Certainly in the younger population, there is a higher re-injury rate. So we'll talk a little bit about that later in terms of age matters, and understanding the age of your athletes when you are collectively making that shared decision is really important. Re-injury is high, and there's some studies out of the UEFA European Soccer League. So professional athletes, certainly, and professional footballers, there's a high percentage that they go back, but only a third of them are still there 3 years later. So that shows you that there is significant consequence about our decisions and are they ready to go back? And there is no magic answer, is what you'll take home from today, but just to get you thinking about some things. And certainly the osteoarthritic knee is not uncommon at very young ages. So if you have an athlete that you've inherited on your list that ruptured their knee at 15, the likelihood is that they're going to have some OA changes radiologically, within that sort of 5-year period. There will be certainly some cartilaginous changes in their patellofemoral joint, which is going to have implications to how much you can load them from a S&C point of view, how much you can actually get out of them on the park. So it certainly has some significant consequences. The reality is time remains the most commonly used metric for return to sport, even though we've got, there is lots of evidence around that. So this is a nice graph that was published earlier this year in BJSM. So up until 1990, pretty much 100% decisions were made on time. And since that point in time, about 50% of published data in terms of return to sport criteria is on time. And then we have started looking at other things such as strength, hop testing, performance-based criteria. The trouble with research, as we know, is there is so many factors and depends on how well the study's done, on what population it's done on, whether it's done on males or females, or whether we can actually extrapolate that to our real-world scenarios. And it's very different in the lab as it is when you are dealing with real people. So there is also a big swell around criteria-based, and we've kind of flicked time a little bit. But the reality is that we kind of have to use both, because you cannot deny the biological healing of tissue, whether it's muscle tissue, whether it's bony healing, whether it's the ligamentization of an ACL graft from whether it's had a previous life as a hamstring tendon, a quads tendon, patellar tendon, whatever that may be. But we certainly know that time has a factor in terms of the strength of the graft. And so that's one component. So I certainly think that whilst criteria-based rehab is really important, we can't forget biology exists. The other thing to remember when you are discussing it with players and with coaching staff is the return to play rate is not as high as we think. In non-elite athletes, it's about over 50%, so it's about half that will return to their pre-injury level. About 60% return to pre-injury level, and competitively it's about 50%, so it's not that high. And in the community space, there is lots of barriers to good rehab. Number one is cost. So in Australia, only a third of people that have an ACL reconstruction will actually do rehab for longer than 3 months. Another third will stick at it till 6 months. And then only a third actually go for a full 12 months. It is expensive to do rehab well, okay? Really expensive. And unless you're with a club or an organisation where there is the support of sports science and good strength and conditioning coaches and high quality physio, it is very hard for mum or dads to sustain that the whole way through, and certainly the government and even insurance policies that are around sort of kids sport doesn't equate to that. If they've had a second reconstruction, the return to pre-injury level is lower than that 65%, it's at 53%. In the professional athlete, the stats are better, and they're in a much more supportive environment. It's largely their job in most parts, so it's much easier to adhere and comply to quality rehab, and there is often a lot more objective measures around that, so the numbers are better. Just going to briefly touch on the psychological impact of injury and the actual psychological well-being of the athlete and how they feel about going back to sport, and certainly around an ACL is significant. So it's the number one factor. Fear of re-injury is the number one factor why that number isn't as big as we think it is. And so measures such as the ACL RSI, which was developed by Kate Webster here in Melbourne with Julian Feller's group, is a really useful mechanism to tick off one part of the box in terms of that their psychological readiness to return. So there's been a couple of really good papers in the last few years that has helped us kind of understand that simple decision rules can substantially reduce risk of injury, but by no means is it the be-all and end-all. They are largely in male populations, certainly the Qatar study is, but what it does do is it gives us a battery of tests that we can look to, because that's all we've got at the moment, and then we can kind of keep developing science as we go from there. You know, there is lots of ways of kind of looking at, like, can you tell from someone's, body position and valgus, is that good or bad? That's how a lot of people are cleared. They've got a good single leg squat, they've got good control. What does that can you tell by looking? So, does a small quad really mean it's not particularly strong? And that can happen very quickly. And even, that can remain way down the track. It's surprising how many people get cleared to go back and they have obvious deficits but that haven't been measured. And then how many people really are isokinetic tests do matter. And it's not a test that's readily available in all clinics, but if you pay or encourage your patients to pay a couple of $100 for a test that is very useful in terms of its information, what's that cost effectiveness like compared to if they go on and re-rupture and down the track? So we do know that quads matter. So these are the two really good papers that I encourage you both to read. So the paper on the left is a combined conglomerate from North America and Norway. It's called the Canine Trial, and there's lots of great papers that have come out of that. So I would strongly encourage you to read that. And then the other one has come out of Aspetar and largely is based on the Qatari Star League, which is a male Middle Eastern population. However, really useful to kind of get us thinking about what are the things that are actually measured, as opposed to thinking, okay, well, they've hit their 9-month mark down the track. Now, I know many of you, if you work in elite sport, it's a lot more complex than that. But in reality, if you're a sole clinician and you're dealing with these things and your surgeon has not seen the player after 3 months and they said you'll be good to go, and they are just using purely time, then that's where these things are going to be really useful for you guys. So in terms of the battery of tests, quad strength certainly comes up time and time again. Hop symmetry, someone can do a single hop for distance, they can triple crossover hop with significant deficits. So there is big flaws in terms of what an actual hop for distance test and limb symmetry index comparing side to side can tell us. We know that for every month after 9 months that the numbers are less, and that's certainly for athletes over the age of 20. And then in the literature, things like agility and sport-specific rehab is described, but it's not specific to any one sport. So you've got to understand your sport, the demands of your sport. If you've got pre-injury data in terms of their performance testing, these are all the things that you can certainly be using as a part of your battery that you'll come up with in your population. So as I said before, quads quads do matter, and there's lots of argument in the Twitter world, and I'm sure in departments about exercises that are functional versus non-functional. Quad strength and knee extensor strength following an ACL injury is absolutely crucial, and you can have a very, very fit athlete that ticks boxes in lots of other ways, but if they are operating at 20 or 30% down one compared to the other side, even better if you've got previous data, that is going to have significant implications into their ability to accept force, their ability to accelerate, decelerate, their long-term knee joint health. So quads do matter, and how you test that matters. So isokinetic dynamometry is the gold standard. There are people that will use 1RM testing, handheld dynamometry. They will overestimate the quads index by they say at least 10. So for every 1% where you've got a comparison of quads index left to right, side to side, you will decrease the chance of your knee injury. So it is really difficult if you've got a young athlete, but it is certainly a really important exercise to do, and you don't do it right at the end. You can certainly do it at 4 months, you can do it at 5 months, you can do it at 9 months, to really give that athlete some quality feedback and allow them opportunity to try and address some of those deficits, and then be able to go on and push further on with more functional type exercises and some other metrics, which we'll talk about in a sec. I don't think there's any evidence of this, but certainly with females, they will get their quad strength, but unless they maintain it and you retest them a year later and 2 years later, they do seem to have a much more significant drop-off post-ACL than the male cohort will. So that's important. This is just some vision that a colleague at Aspetar, Athol Thompson, who's an Australian podiatrist, has kindly lent me, really just to help highlight you can have great metrics on your quads index, hop testing. They can be psychologically ready. To the naked eye, you can be doing a drop vertical jump. You could do some of the less, which is another landing strategy, markable exercise. But what we don't know is what's going on underneath and how the leg or the limb's got the ability to absorb force. So if you can see on the right, hopefully this works. Okay, so on the right is him running on the treadmill. To the naked eye, you cannot pick which leg it is. But you can see, if you can see the numbers down the bottom, there is a massive discrepancy in terms of the vertical ground reaction force. So what that tells us is we're not getting all the information from the current tests that we do, which is where something like force plates, certainly now becoming much more accessible, can give us information in terms of how the player has the ability to accept that vertical ground reaction force, accept the ability to decelerate, and their knee can do that in different planes, whether it's moving forward, moving sideways. It certainly opens up lots of opportunity to explore what we don't know even further, I think. And I think this is really the key. I think the other thing that is probably the key that we don't know yet is looking at rate of force development. So over the last couple of years, the clinic that I have been a partner of for a long time in Adelaide, we did a 2-year data collection for Dave Opar's group here at ACU, and what we're looking at is things like isometric RFD of quad and hamstring. If we had have done the study again, it would have been great to have force plates as well to be able to look at that. So there are a number of metrics that we've been looking at to see, and then follow up at 2 years and 5 years. And this is in a large community sort of space where we've got male and females aging from 15 to 40, which if you look at the data, there is very little data out there in terms of what happens with that cohort, and certainly with the younger athletes. So watch this space. Hopefully there'll be some stuff to come out of that next year. But the take home of that is you cannot tell by looking at someone, okay? And we've come a long way from hop testing, but we still use it quite a lot. So there's a significant deficit there, as you can see. So thank you, Athol. The last thing that I want to really highlight is if you have players that are under the age of 20, their stats are not as good as if you're over 20, so you need to be aware. That's not wrapping them up in cotton wool, but that is certainly saying that you need to treat them differently. You need to educate your coaches that you need to treat them differently, because they have a higher rate of recurrence than the more mature athlete. if you're a 15-year-old promising athlete, a ACL injury is devastating. It is not the end of your career. So having worked with the Matildas for a long time, Sam Kerr did her ACL when she was 16, and she will say from an athletic development point of view, it was the thing that kick-started her actual role into being a much better athlete. She was an incredibly gifted junior, incredibly gifted, but didn't work hard, and what that taught her was to work hard. And now she's certainly one of the most recognisable faces in Australia. So you can go on and have an amazing career if you do it young, but you've got to have the support network around you, and you've got to be able to make sure that there is some processes in place that you don't go back too early. So age absolutely matters. When we talk about shared decision making, I don't know if anyone's familiar with this work of Ian Schreier, who's a Canadian, but really these are all the things that we're talking about. You have to consider the tissue health, which describes someone's age, their symptoms, whether they've got ongoing swelling in their knee, and all the physical testing in terms of looking at their strength parameters and so forth. And then there are other stresses around that, and then there are things that may influence your decision or influence the player's decision to make it whether they come back earlier or not. And that might be a grand final, it might be an Olympic cycle which comes every 4 years. And so largely the decision is theirs in most things in sport except for concussion. But it is really our job to kind of lay the facts on the table and present that case in the most supportive way that you can. So you can only do that if you understand all the kind of mechanics behind that and all the variables behind that. So it's important to consider all those things. And then, as I said, it gets a bit more confusing when there are multiple stakeholders, multiple people that have an agenda, if you like. And that certainly, was my experience with the professional rise of women's sport in my time. So when I started with the Matildas, we were largely the only medical staff that worried about the players. Then you start getting W League clubs come in, start getting overseas clubs come in. So if you're trying to manage a player with multiple stakeholders, you have to be very clear on what the path is and what the return to play plan looks like from day one, and get some form of consensus. You're never all going to agree, but you certainly need to make the player the centre of that. I saw this on Twitter yesterday, and this is a paper that's just come out about whether a lack of knee flexion will determine whether you come back and play early. Now, I'm not bagging that paper, but what I am making it clear is that only those patients who were cleared to return by the treating surgeon were eligible for this study. This happens all the time, and if you inherit a player and you say, oh, what sorts of things did you have to do to go back and play? Most of the time, there was no process. The surgeon said I'd be good to go. The surgeon's definition of good to go is that there is no effusion and they have a strong Lockman's. That is it. They don't understand the demands of the sport or all those other things. So we have to really be the advocate for the player and make sure that we've got a really clear case that you can argue. So in summary, I think the successful return to play, whether it's an ACL, whether it's any decision, really starts day one. You've got to see what the end point is and work back from there, see what all the things that they need to be able to do, what other things are actually wrong, is there any other pathology that may influence your decision early on, and really determine what is better and what is successful. What's successful for me is maybe very different to what's successful for the player, so and for the coach. So we've got to be able to make sure that everyone is on the same page and being really transparent with your information, making sure that you don't keep it a secret, but all these things that they need to be able to do are really clear from day one, and being able to understand the training loads and the demands and embracing technology as they come. So research, is a little behind what we're doing often in elite sport. We're trying new things, but I certainly think that getting some extra visuals and some other metrics around ground reaction force and certainly the force plates from an ACL space, I think is going to be really, really useful and a really exciting thing to be able to start to implement as we go along. I've just got my little video, if it works. So no matter how good your training program is, shit happens. I don't know if anyone's seen this before, but you can train for all the things that you expect in a game scenario, but you can't control what the players do all the time. So life is unpredictable, sport's unpredictable. There goes his ACL. Now you could argue that there's traction forces involved, there's gone from grass to synthetic, but you know, if your player's got the propensity to go and do cartwheels, do backflips like Sam Kerr does, imagine my gut when I saw her do a backflip for the first time having an ACL, I was like, nearly had a heart attack. But you've got to be able to train them, you know, you've got to prepare for the worst case scenario. I'm not saying you need to go and get them to do that all the time. But I guess the return to play starts from the moment of injury. Simple test, do the simple stuff well. So I don't care if it's not functional. You know, functional exercise is having to make a split decision at full speed, you know, and change on a dime. You can't necessarily train that. Train the deficits really well. Make sure you've cleared that first before you get fancy. The current return to play literature certainly has its limitations. Beware of someone that you inherit, as I said, that has an ACL, and making sure that you get really good at your communication and including the key stakeholders in that decision, but ultimately, really the player needs to be the centre. So, thank you.